So in the last but one session, Mark was introducing you to the concept that if we start to enter data into the system more or less in real time, that the audit team will be able to feed you back data more or less in real time to inform your practice. So what I would like to do in the next half an hour or so is to run through how that might work and why we think that's a good idea. And then we're going to have a session at the tables to do some practical work, which we'll explain in a moment or two, and the facilitators will support you in that. And then the final session before lunch will be a talk from Peter Wilkinson, who's a fellow cardiologist, who will talk about some practical QI applications in cardiology, quality improvement. Great. And Mark, in a sense, has already covered this, but I think it's still important for us just to remember that I'm guessing that everybody here, when they come to work, think they're going to do a good job for their patients, and I would imagine most of you go home in the evening thinking you did a good job for your patients. Every now and again, something bad will happen, and there'll be a patient complaint or an unexpected death or an SUI of some kind, but fortunately that's pretty infrequent. And if we're going to use those very crude measures only to determine whether our service is a good service or not, we're going to miss a huge amount of granularity under the system. So we do need data, a variety of different kinds, to help inform our understanding of our own service. And as clinicians and managers, healthcare professionals of whatever ilk, I would argue again that we do all have a responsibility to make sure that our service delivered to our patients is as good as it possibly can be, and not feel that that responsibility lies with the government, with the management, with someone else. But we all have a role to play in that. And I thought that talk from Louise was so compelling. If you weren't moved by that, to think that you really want to help people like her, then I think that would be very sad. So I'm assuming that everybody's in the same boat here. So how do we know how good our service is? Well, it has to be by looking at the data. And as Mark says, the data has to be good quality. If we put rubbish in, we'll get rubbish out. So let's assume we're not going to do that. So I'm just going to challenge some assumptions, and maybe we'll find that actually everybody in the room is perfectly sighted on the data and really understands what's going on. So I appreciate that some of you will come from a more specialized area within the cardiac field, and this may not be something you deal with intentionally. But there are two standards here for PCI that I want you just to have a reflect on for a moment. So the first is a national target that all eligible patients should have a call to balloon time of less than 150 minutes. And target 2 is that at least 75% of all patients should have a door to balloon time of less than 60 minutes. Okay, so two standards that we have. Now, I would argue that if we are delivering a good service, we should meet those standards. Yeah? Anybody think that we can deliver a good service and not meet those standards? So we're signed up to that. So two things. How do you think we're doing now? Are we meeting those standards as a country? You know, the great National Health Service, are we the great National Health Service? And over 8 years of recording information and data through the audit programme, how much improvement do you think there's been from 8 years ago to now? So to answer those questions, I'd like you to go back into Slido again. So, yeah, so if you don't mind doing that. So to remind you, okay, so here's the first question that should pop up. So what percentage of patients have a call to balloon time of less than 150 minutes? We were talking about 100% was the standard, yeah? Here's the standard, by the way, down here, 100. So not very confident at the moment. Oh dear. I mean, it's good we haven't got the patient in the room. They might be feeling a little bit upset at this stage. Do you think? Do you think they might be? So our own assumption is that it's, we've got a random 80-70 in there, but anyway, somewhere maybe 80%, something around that. So what's the answer? So the data, the audit data tells us it's about 70%. Okay, so well below the national standard. So that's interesting, isn't it? So we come to work thinking we're doing a great job. We think the NHS is the paragon of virtue that the rest of the world should be judged by, and we're not meeting our own standards, not just by a little bit, but by a significant amount. Okay, the next question then is coming up. Sorry, let me make that. It's on the screen, but not on here. Okay, what percentage of patients have a Doortoballoon time of less than 60 minutes? So it's 75% was the target, I think. My goodness, you're becoming very cynical after that first one, aren't you? Underperformance is the norm. Okay. And the answer is? 90%. So, oh yes, hooray. So I think what that tells us is that sometimes the data tells us we're not doing as well as we think we are, but sometimes, and this is the thing about audit, the data tells us we're doing really well in an area, and that's something to be proud of and to share and to celebrate and to understand why that's happened so we can share that good practice and put it into other areas. So it isn't all doom and gloom. Sometimes it's really positive stuff. But the point I'm trying to make is that the majority of people didn't get that right. And they didn't get the last one right either. So we think we know, but we don't know, actually. And the only way we will know is if we actually measure and report back information to ourselves. So that's important. So the next question is, how much better are we at call to balloon time over the last 8 years? What we know is if you feed data back through audit, you can expect an improvement of roughly 0 to 1% per year on average, sometimes up to 2%. So how much improvement do you think we've had over the last 8 years in call to balloon time? This is a really interesting psychosocial study, actually, I think, which I'll comment on in a moment. But I'm really enjoying this. I don't know about you. Hopefully you're finding it quite interesting. Okay, so on the first Slido we had, you kind of over-optimistic about what was going on. Then the second one, you were under-optimistic. So now you've become over-optimistic again. And the reality is, real score, we've actually got worse. Okay? So we've actually got worse. So that's worrying, isn't it? Yeah, intake of breath. And you know, let's now populate the room with patients, and what would they be thinking about this? And then what's our responsibility? Well, it's the ambulance, or it's, you know, well, actually, what can we do about that? What can we work in there, I think, is the question. Next one, please. Next Slido. So I've got to put this on, haven't I? Yep. So next one is, what about door to balloon time? What's happened in the last 8 years over that? Remembering anything from 0 to 1% kind of improvement per year we might expect to get. Yeah, it's going well. Okay, and the real answer, the right answer, please? +1. Okay, so again, the minority guessed that, but at least there's been some improvement, but not a huge amount. So some challenges for us there. The point being, unless we know the data, it's very difficult for us to understand how we're doing, and therefore what we can celebrate as successful, and therefore spread and adopt, and what we need to do something about, where we need to make the difference. Okay, so now I'm just going to have to advance the slide set, which seems to have stuck. Right. One more. Good. Right, fine. So these are the data just for us to have a look at, collected through the audit program, and you can see that call to balloon time has been going down, getting worse, sorry, our compliance with that, and quite significantly, whereas door to balloon time has been up and down a little bit. You could argue it's probably not changed at all during that time, but it's a little bit better if you measure one against the other. But that's a bit worrying. So we can use data for lots of things, and I don't want us to get stuck on this is all about beating us over the head because we're not doing well. There are lots of things that we can do that are positive with data as well. But we need the data to be able to assess our current performance. We need to use the data to identify gaps in performance. Where are we not doing well, so we can make make a difference, and then to prioritize, because one of the problems in the past with audit data was you'd get this thick report and it would report on 120 metrics, and 119 of them needed some improvement, and the first thought about that is it's impossible, I can't do anything about it. Well, we're still going to collect data, but narrow the field down a little bit. But the important thing is to have a look at those metrics and decide, well, in terms of a quality improvement plan, I can't make 119 things better next year. What can I do, looking down that list, that would really make a difference? Let me choose one or two or maybe three things maximum out of that list that I can make a difference to. Things that are more in my control. So if the answer to the question is how do I make that better is, well, I need 26 more beds and 3 more consultants and 6 more nurses, you know that's not going to happen. So that's not the thing that's going to be your priority. Likewise, if it's something which if you improve it from 99% to 99.5% is hardly going to have any impact on the system, that's probably not the thing to choose either. So you can use the data to try to think, where if I make the input, will I get the biggest bang for my bucks for patient care? So I think that's really important to do that. It helps you also make a case for improvement. If you go to your managers, if you go to your trust finance officer or transformation team and say, we need to invest in my service, the first question is why? And what's the evidence? And what are you going to do about it? What's your plan? If you've got data, you're halfway there, because most people don't have the data to support their argument. So use the data in that constructive way. And likewise, if you're doing well, as it seems that we are in some areas, use that also in terms of saying, look, that investment you made has now produced this improvement, so you therefore need to continue to make that investment in the service rather than take it away as part of the cuts. And finally, and I think this is really important against talking about our colleagues, because you will know that if we're going to get change, we have to work as a team, but that means involving all our colleagues as well. And you will know there are people in your teams who are the naysayers, who say, oh, there's nothing we can do about it, it's all hopeless, it's terrible, until the government does this, and da-da-da-da. Use the data, though, to challenge them, to say, look, this is something that's within our own remit, something that we can do something about, and here's the evidence. And bring a patient into that discussion. I mean, there are few people who could resist the kind of compelling argument that we heard from our patient a moment ago. So data, 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 really, really important. There is also, nicely, an evidence base around data and how important it is and what kind of data helps us make change happen. And it's not just any old data. So we know from audit that audit does make a difference, but it's a small difference. Now, at a national scale, that's important. 1% of 1 million people getting better care every year is significant for those people. So that's important. But in my organisation, where I may be seeing 500 or 600 people, that's a small number of people who I'm going to see an improvement on. So we need to do a little bit more than just feeding data back to people about their performance. We know that certain things will make an improvement. And perhaps it's quite logical to think that if you're doing badly to begin with, then you've got more chance to improve. But that's encouraging if we're feeling we're towards the bottom of the pile. Feeding back information and data, colleague to colleague, much more compelling than somebody else, a manager, telling the chief cardiologist that we need to do something about it, or somebody like me, for instance, coming to your department and saying, I'm a national person and I'm telling you in your department you need to do something about it. But if you've got a champion, if you are telling your colleagues that we need to make a difference, that's much more compelling. You need to give people data, not just once in an annual report and say, here it is, but you need to continually to give them data. So the best way is if you have a departmental meeting, you discuss your data every departmental meeting. You might, for example, have a board on your ward in your departmental room, if you have a departmental room, and so lucky to have one these days, but on your ward, which charts your progress. So the data is there, and you update it every week, so everybody can see it. But feeding back the data continuously is so much more compelling than the annual report will be out in another year. We'll wait and see what it shows before we look at it again. And that's where the continuous data comes in. There is a strong evidence base to show that continuous data feeds Real-time data in, real-time data out makes much more difference in terms of improving services than intermittent data collection every 6 months or every year. You have to provide it in different formats, so putting something on the wall, a poster people can see, talking to people at meetings, providing the data through email, electronic reporting, all different ways makes a difference. And you need to set some targets. So we had those targets before, but setting targets for the department. So rather than just saying, look, we should be at 75% and we're at 68%, we need to do better, isn't good enough. You need to say we need to get from 68 to 70% in the next few months. Set a date for that. So you've got a target to go for, and everybody understands that's the target, and everybody's working towards the same target, and they all accept and sign up for that target. And then you need to give people an action plan. Again, it's no good saying we're going to do better. How are we going to do better? So as a group, we need to sit down and work out how we're going to do better. So you need to have an action plan to help people understand what they can do to make the difference that they need to make in the system. So let's just go back to that question about continuous data, because the problem is we don't put continuous data in because it's harder. It's much easier for us to say, okay, in 3 months I'm going to put a day aside, pull all the cases, all the electronic records, and I'll put it all into the system then. But that doesn't give us the richness of information that we really need if we're going to use it for continuous improvement. So this is the classical way, and it doesn't matter what these metrics are, ignore them in a sense. But we collect data here, then we make a change, and then we collect data again. And that's how we've looked at things. And that time period can be a year, or 2 years, or 3 years, or 6 months, or whatever, but that's the way we do it. And just in the room now, does anybody think that this was the waiting time before for the procedure, this is the waiting time now, and it's gone down from 8 to 3, whatever that is, days, weeks, months, hours, minutes, it doesn't matter. Does anybody here think that we haven't made an improvement? So we did a lot of stuff here, we invested in staff, time, changed the pathway, and things changed. So yeah, so it's obvious, isn't it? We made an improvement, yeah? Definitely? Yeah, we made an improvement. Well, maybe we did, maybe we didn't. So this is a different way, and Mark demonstrated this very eloquently earlier, about using time sequences or run charts to produce data formatting instead. So if you're producing continuous data, you can feed it back in a fairly continuous format. So along the x-axis, we've got the time sequence. And again, this can be every week, every month, whatever it is, but you give data back to people, to the sites, to you, on the first day of the month, for example, January, February, March, April, May, June, July, etc., going along there. And along the y-axis, you've got whatever the measure is, Doortoballoon time, waiting time, or achievement levels, or whatever that might be. And you can then start to see a pattern emerging. And if you make an intervention here, you can see very quickly whether that has made a difference, rather than waiting for another year for your next collection of audit data to see if it has made a difference or not. So let's just go back to that before and after again. So here's where we were, this is the change we made, and this is where we came to. Obviously, we've got better. So the assumption being that if we were looking at a time chart again, as we said a moment ago, so here again, this is the time waiting to be seen or to have the procedure, and these are the months along this x-axis of data. So this block here, we assume, looks like that over time. Yeah, things were the same. And we assume that afterwards, it's now like that. But actually, that might not be the case. We don't know that. That's an assumption we've made. So for example, and I'll have to get the pointer now, because I'm not that tall. So for example, what we may have done is been measuring at this point, and then again at this point, or this point. And what we're actually seeing is two changes, two time points along something which really hasn't changed very much. We're just seeing a natural variation in our data. Or we may be measuring here, and then measuring again here, having made a change here, and we were seeing an improvement way beyond the change. So with all that investment we made, and the changes in the pathway, and all the extra work it gave to us, was a complete waste of time, because we were already on a course for improvement, we just didn't know it, and it hasn't had any change in the trajectory. Or this might have been correct, that we were pretty rubbish, and then we made a change, and yay, yeah, we did get that, fantastic. But then over time, we slip back again, and we won't know that if we're just measuring an average from here. And that's often, we see that in the NHS. We've had a clinical leader, somebody who invested time in making the change, then they left, and it all falls back again. And there are other patterns as well. The point being, this allows you, if we're using a time series chart, it allows you to see real change, so you can be more confident about what's going on. And if you make a change in the system, you have an opportunity in real time to understand whether that change in the system is really having the impact that you hope it is. So run charts, in essence, allow us to identify trends and patterns. It can be anything. Here we're talking about sales of books, about QI. You can compare the performance measure before and after change, which is really important, but also, and again, Mark mentioned this to you, you can compare your performance against bigger groups, which could be a national average, it can be a target, it can be the top 10 sites, whatever it is that you choose. And I'll give you some examples of that now. So the other thing just to mention about looking at run charts is that there are certain patterns that we see in run charts that are important for us to understand. So if we see 6 points all moving in the same direction, it has to be 6, that's statistically very, very likely to be a significant observation. So 6 points going down tell us well, whatever that is, the time is getting less. If we see 6 points going in the other direction, yeah, that's also likely to be significant. But if we see 2 points which are the same on the scale, so for example here, we've got point 1, and then we've got 2 points the same, those 2 points count as a single point. So we've got 1 point going in that direction, 2 points, 3 points because they're the same, 4, 5, 6. So that would be, again, significant. But we didn't have the top 2 points. We'd be looking at a change, but not knowing whether that's a significant change. In the middle here, we've got what we see as a kind of a random variation. And there are different reasons why we might get that. It could be there are all sorts of factors that change by day, or week by week, or month by month, depending upon what the time sequence is. Or it can be an issue around data entry. So we're not entering enough cases. So suddenly we see a big shift and a swing because we haven't got the data in appropriately. So there's a number of patterns that we see in QI charts that tell us whether something that's happening there is real or whether it's some kind of chance observation. Sorry, I seem to be getting stuck on a couple of slides. This is the kind of thing we're hoping that you will see shortly, and this is an example of Doortoballoon time. So here, the red line in the middle is the average for your hospital. This is your hospital we're reporting now. The blue line is your hospital performance, and the green line is the national target. And as Mark said, we could add in there the top 10 hospitals as well. And what you can see there is that although you made a change here on the 1st of April, nothing much happened. So you can tell pretty quickly that the change you made isn't going to help. So you need to change the change and improve it rather than wait a year for your next data collection to say, yeah, that change we made in April didn't work for the last 12 months. What a waste of time that was for us. Alternatively, you might see something like this, where you did make a change and it looks now as if there is a trend towards improvement and you're going towards the national average. You still have a lot of work to do, so I think that's important too. And as Mark said, what we don't want to do is all be mediocre. So aiming to be average is probably not good enough. We need to be better than average. We need to push that average line up, and we need to be aspiring to be amongst the top performing units. But again, by using that time analysis, we get those patterns and we can understand them better. Alternatively, we may see something like this, which is the random variation effect. Now, there could be some reasons for that, and sometimes we see patterns. So, for example, we might find, if we're doing this over a couple of years, that we always have a fall off in performance maybe in the winter, and that's an explanation. That doesn't mean, however, that we then just say, okay, fine, there's nothing we do about winters. Winters happen. We need to think about, well, what do? We know that every winter we have a fall off. What can we do? Put more staff in, change our pathways, do something that will help us understand and put in a plan for improvement at that time. But this could also be because during that period, the data entry person went on holiday, and so the data didn't go in. Or somebody else put the data in but didn't get the coding right and put in the wrong data. So you have to think about those issues as well. But what these charts don't do is give you all the answers. They don't tell you why and what's going on. So they'll tell you there's an analysis, a trend. They'll tell you what your performance is like. They'll tell you whether you're getting better, getting worse. They'll tell you whether you've got a problem probably with data entry or some other random variation coming in, but they're not going to give you all the answers to the problem. So the next part of what we need to do is to actually do a deep dive into the data to find out what else, What other data sources can we pull into the system that will help us understand why we're not doing well or why we've had a dip in the system? So with this afternoon, we're going to look at some of these things. I'm just setting up this afternoon's talk for you, some tools to help you, some methodological approaches that help you understand how to use the data and how we can try and get, in a sense, to the cause of the problem. Process mapping is a really important one. You know, what's going on in the system from the moment the patient starts the call to the moment they get the angioplasty or the balloon time. And sometimes that tells us where the blocks are in the system and what the delays might be, for example. Fishbone diagrams we'll talk about in terms of looking at the processes that go into an issue or a problem, and tools that we can use to make a change. Diagram, driver diagrams, smart aims, and PDSA cycles we'll go into in some detail this afternoon. The point I'm making is that there's a methodological approach you can use to help you analyze what the issues are in your department, which you can also use to help you understand how to make a change which is more likely to be effective. The Health Foundation, which are probably the most well-known UK organisation in terms of improvement, say that once we've got data, this is how you need to use it. So we've had a look at the data, we've got an understanding of what's going on, but how can we use it to argue for change as well within our organisations, our commissioners or our trust? And these are kind of 5 things that they say are really important around engaging the right people. So the first thing is, who do I need to engage? Is this about patients? Is this about engaging my own board? Is it about engaging externally commissioners? Who is it? Or do I want to go out to the British Heart Foundation and engage them for some additional funding for something? So what's the argument I need to make? So know your audience so that you can have the right messages. Make sure that the messages that you have are really strong and targeted. So it's not, there's 119 things we need to do better, but it is the one thing we need to do better is this. And in order to do this, we need that and that. So have a really strong message. Engaging clinical champions, really important again, or patient champions. And we'll talk more about that this afternoon. But we need to have champions on our side who are going to take this forward. It's mainly us, the clinical leaders, that do that kind of thing. But we need to have those people identified and ready to take this forward. And then think about the money. Now, that can be taken literally because money is so important. So aligning your improvement program towards financial requirements of the trust can be really important. So again, going in saying we need 15 more beds, 3 more consultants, 6 more nurses in a trust which is strapped for cash is just never going to run, and you know that. So let's not set ourselves up to fail by putting that as our QI aim, our quality improvement aim. Let's instead find something which aligns more to the trust requirements. So if the trust has got a problem with beds, and we can say, look, this improvement will reduce the length of stay by a day or half a day, that chimes with what the trust needs to do. If the trust has got a CQC coming along and you've got a problem with your door-to-balloon times, you can say, we can help you with that by putting in this investment that will make a difference to the system. So you need to align very much to the organisational requirements. When it's your colleagues who are causing problems, you might say to them, well, look, this will help you with your revalidation. If you take part in this programme, it's something you have to do for revalidation. Trainees who are around you who need to do a QI project every year as part of their sign-off, say, look, here's a national one. Let's not do how do we rearrange the deck chairs in the waiting room, which is so many QI projects are about, but let's use national data to make a big difference for patients in a way that we know is important. So those kind of things will help you very much in getting the right people engaged and in the room for you. So just to summarise, and I hope, again, this is so obvious now that I don't really need to say it again, but I will do anyway. Without using data, it's very difficult to know if we're giving really good care or not. The data helps us to understand what the problems are, where we should make the interventions, and then it tells us when we've made those interventions whether they're effective or not. Without the data and without real-time data, it's very, very difficult to do those things. We really are shooting in the dark. It's not a great way forward. And don't forget, this is all about giving better care to the patients. We need to have that in our minds. So I'm going to stop there, and then I'm going to ask now for us to look at something you should have on your desks, which is a workshop session now.